Assalamu alaikum. Today we'll be discussing acute type B dissection. When we treat these patients, when we don't treat, when we use dissection stent, it's going to be a brief, precise presentation about what it is currently considered standard care, and about how I do and we do things in our institution and how most people do it. In 220 there was a new classification for type A and type B dissection, and a new reporting standard which was really very helpful, and it really describes the disease accurately in terms of endovascular era. I am not going to go through the entire paper. The paper is available for free online. You can take a look at it and practice different scenarios, which is in the paper as well. But what I wanted to point out here is this classification basically discusses the chronicity, meaning the timing, what hyperacute means, what acute means, what subacute means, and these are important definitions. The acute type B dissection and uncomplicated, high risk features and complicated. And then lastly talks about a false lumen reporting standards, which is very important as well. This is a widely accepted classification now. There are 797 publications since 2020 that discuss in type B dissection. 70% have these publications have referenced this classification. So it's very widely used, very widely accepted. False lumen reporting, I want to just to be brief. Type 1 and type 1A and 1B leaks are normal, like you would do for EVAR. They have a type 2 leak here in thoracic or in dissection, means a branch leak. This could be subclavian, could be renal, could be SMA, could be a false lumen communication and then could be a lumbar, could be whatever. So, and then type R entry flow is produced by flow into the false lumen from the true lumen via a septal fenestrations, and that sometimes excuse me, what causes the false lumen to enlarge. And this is an important distinction that we have to we have to appreciate and know very well. A complicated type B dissection means there's rupture or malperfusion. That's it. Rupture or malperfusion. No more. It's very straightforward, very simple. Uncomplicated is no rupture, no malperfusion, and no high-risk features. High-risk features are very important to recognize, because these days, if you have high-risk features, you should be treated early. And we'll go over them in the next slide. How about high-risk features? So the way I like to look at high-risk features are divided into two categories. Is clinical or clinical features, such as refractory pain, refractory hypertension, and readmission. These patients that they are considered with high-risk features. So if you have someone had chest pain and was found to have type B dissection, then their pain resolved, then they were readmitted 2 or 3 weeks later, that's a high-risk feature. And there are radiographic high-risk features, such as aortic diameter more than 40 millimeter, radiographic only malperfusion, which is usually a false lumen, big, true lumen, like false lumen, true lumen in the abdomen or the paravisceral area or wherever it is, or if it's very, very narrow, atretic, true lumen, then that's considered to be a radiographic malperfusion. Entry tear on the listal curve of the listal curve location. These are usually high-risk features. Bloody pleural effusion and false lumen more than 22 millimeter. The high-risk feature. What do data and experience say? So if you have high-risk feature, these patients are most likely to progress into a complicated type B dissection, meaning these patients are likely to be readmitted, these patients are likely to have aneurysmal dilation, they're more likely to progress to some kind of malperfusion, etc. The most important clinical predictors of mortality in these patients is is pain and hypertension. So in hospital mortality significantly increases when you have a refractory hypertension that's difficult to control. You need multiple drips to control it, and when you have pain that is not resolving with just normal pain medication, those patients have poorer prognosis, if you will, and they need intervention. The intervention has been shown to improve outcome in these patients, basically. Aortic remodeling in 2 weeks. So take a look at the same patient. So you see the false lumen here, the true lumen, sorry. That's a true lumen. That's pre-TVAR. Post-TVAR at 2 weeks, and that, you see, the remodeling is pretty good. This is in the thoracic aorta. When you look at day 1, day 4, and 1 day post, day 4 the procedure, then 1 day post procedure, and when you look 9 weeks, you see the thoracic aorta almost has no false lumen. You see here. In this trial, the adsorb trial, which is a gore trial, looked into a tag plus best medical therapy in terms of outcome and with medical therapy alone. And what they found that basically the diameter of the true lumen has remodeled more. You see with tag group here, and when you look at the false lumen size, has decreased also a lot when you used a tag plus best medical therapy. This is a Instead XL trial, which is a trial was done on uncomplicated type B dissection. Essentially, what you see here is absolute risk reduction of aortic specific mortality at 5 years follow-up. When you do TVAR and optimal medical therapy, you have a 12.4% basically absolute reduction, risk reduction. And as far as for disease progression, and namely or mainly aortic degeneration and aneurysmal degeneration, is 19.1%. So some argue that this trial is not powered enough. It's a small number of patients to come to this conclusion. But there's a merit to treat some of those patients, especially as we mentioned, patients with high risk features and patients who have multiple admissions and malperfusion, radiographic malperfusion. When you look at this trial, is a Medtronic trial, very sick patient cohort, presented with DeBakey class 3 dissection, extending to or past the diaphragm. 86 clinically had malperfusion, 20% had actually rupture. They found that freedom from all-cause mortality was 65%. Freedom from dissection-related mortality was 82.5%, so 83% in this case. There was acceptable basically results, and you see treating these patients with complicated disease, definitely there's merit into treating those patients. This trial looked into patients with uncomplicated type B dissection, how many high-risk features they have, and it came out of Texas, University of Texas, basically, Houston. 256 patients with uncomplicated type B dissection, but they found at least 69% of those patients had at least one high-risk criteria. In another trial, another study from Massachusetts General Hospital, they looked between the year 2000 and December 2013. What they found is interesting. During the trial, for uncomplicated patients, they required that 38% of patients required intervention just through the follow-up of 6.8 years. So these patients do progress to aneurysmal dilation. Sometimes they get another issues with malperfusion and so forth. The natural history of medically managed uncomplicated acute type B dissection. If you look at the Mass General study over a 12-year period, what they found is basically 58.4% failed medical therapy. Those patients who ultimately required intervention and had significant survival advantage. As you see in this graph, basically, there's a huge difference between those who was treated with TVAR and who was treated medically. So 76% survival rate as opposed to 59% survival rate. Systematic review and meta-analysis of evidence in endograft therapy versus medical therapy of uncomplicated type B dissection. What they found is basically TVAR had a significantly lower incidence of adverse events, including aortic rupture, reintervention, aortic-related death, and all-cause mortality when you compare it to a best medical therapy. When you look at the society guidelines, European Society of Cardiology and European Society of Vascular Surgery, they recommended TVAR basically in complicated type B dissection and selective TVAR in uncomplicated type B dissection for prevention of problems. Recent Society of Thoracic Surgeon, American Association of Thoracic Surgery Clinical Practice Guideline has recommended a prophylactic TVAR may be considered in patients with uncomplicated type B dissection to reduce aortic-related adverse event. In this study, they looked at basically what happens if you treat subacute type B dissection versus chronic. The complete obliteration of the false lumen is more likely to occur in acute and subacute cases than chronic cases. I mean, today we're doing, laser septectomies and things like that. These septums are very thick, and sometimes we stent, we just use the false lumen as a conduit. So the false lumen becomes very rigid, very big, sometimes, or the septum, in between the false lumen and the true lumen becomes very hard to break sometimes. When you look at the midterm outcome and aortic remodeling after thoracic endovascular repair for acute and subacute and chronic dissection in the virtue registry, what they found that the aorta still maintain its plasticity within 92 days. We look at this graph. The red and the blue lines are acute and subacute, and the freedom of reintervention is about the same. The freedom of reintervention decreases dramatically when the patient becomes acute. When you look at the subacute cohort, has significantly greater false lumen area regression than patient with chronic dissection. And there is no difference between false lumen regression in the subacute and the acute group, as you see nicely on this graph. The timing. There's a lot of study, and I didn't put them here. There's a lot of recent studies that basically talks about when do you actually do TEVAR. Almost every study I looked into did not recommend to do TEVAR in the hyperacute stage unless you have to. So if you have acute malperfusion, if you have rupture, then you're stuck, you have to do it. But as far as doing in the subacute and acute, there's more risk in the acute stage. The best way to do these cases in the subacute stage, unanimously, are almost all studies show that. And if you look here overall, major complication in the hyperacute stage is 32% versus 10.3% in the acute stage versus 8.3% in the subacute stage. Now, why even this argument exists about TEVAR and not TEVAR? Because doing a TEVAR is not walk in the park. So this is a VQI study that looked into what happened when you do the TEVAR routinely for uncomplicated type B dissection. So they found that stroke rate 2.5% to 10%, spinal cord ischemia risk 4 to 11%, mortality 2.5 to 6.6%. So there are risks for TEVAR. That's why you want to treat patients that need to be treated. There's a solid argument, to treat patients with high-risk features, but patient with uncomplicated features and true uncomplicated features or uncomplicated TEVAR maybe should be treated medically, these patients. Again, when you look at the retrograde dissection in another study, it's 3.2% when you're doing TEVAR for uncomplicated disease. Yeah, when you're doing TEVAR for basically this phenomenon known as a distal stent-induced re-entry tear, and that is 7.1% at 5 years. So patient with true uncomplicated type B dissection, they don't need that risk. And this is the argument, There's a lot of people treat these patients, but I believe strongly if you have a true uncomplicated type B dissection, this patient's best treated with medical. I wanted to talk briefly about the timing of TEVAR, and it was nicely put by Dr. Azizadeh at Cedar Sinai, and I modified it a little bit, but pretty much we do the same thing in our institution, but it was nicely put. So if you have a complicated acute type B dissection and you have rupture or malperfusion, this is an emergency. It has to be done right away. Or if the patient cannot, within 24 hours, within less than 24 hours. If you have a high risk feature with a patient with chest pain or refractory hypertension, these patients need to be done at the same admission, which is in the acute stage of the disease. If you have a radiographic malperfusion or you have a imaging features, or you have a diameter more than 4 millimeter, these patients can be treated at the subacute stage between 14 days to 90 days. And that's pretty much how we do things here in our institution. And it was very nicely put by the physician, Dr. Azizadeh, and it's very straightforward, very easy, and I think it's very helpful. Now, briefly, I would touch base on dissection stent or composite stent, which is a covered stent on top and a open cell stent at the bottom here. Dissection stent is available by Cook right now, and this is a separate talk by itself, but I'm going to touch briefly because it is part of the treatment for acute aortic dissection, at least currently being done by many. This study was done basically a comparison between two European centers who does TEVAR, only TEVAR for acute type B dissection with malperfusion, and when they compared these patients to cohort in the stabilized technique, in the stable trial 1 and 2, and what they found is basically the patients who have had dissection stent, they had less mortality related to the malperfusion than those who just had a TEVAR. And the 30-day rates of morbidity and mortality or secondary interventions were similar between the groups, but the patient had less mortality for malperfusion. I can tell you, we have been using in our institution a lot of dissection stent for malperfusion, and most of the time works really well. And I think it's part of, at least is going to be probably for many, part of the treatment of acute type B dissection. If you look at the finding from stable 1 and stable 2 trials, the 30-day mortality was 6.5%. 5-year freedom from dissection-related mortality is 97%. This is pretty good. This is really good. When you look at the false lumen thrombosis, immediately post-op, you see is about, let's say, close to 50% of these patients had immediately or partial thrombosis, basically. In 5 years with the dissection stent, about 81% of these patients had complete thrombosis of the false lumen, and maybe let's say 10% of them had no false lumen at all, and 5 or 10% had a partial occlusion of the false lumen, and that's or partial thrombosis of the false lumen, and that's pretty good results. When you don't use dissection stent, remember that 5-year follow-up I showed you on IVIS and a CT scan earlier. You see, that's what reflects is about half of those patients have thrombosis of the false lumen, but half of them, or more than half actually, or less than half, I'm sorry, have basically partial thrombosis, basically. So this study was a huge influence and success in terms of modifying treatment for acute type B dissection, especially when you have very small false lumen. So in our practice, we use this technique routinely, almost routinely, on most of acute dissection right now. After stable 1 and stable 2, a lot of operators, especially in Italy, in Milano, they promoted the idea of ballooning further that dissection stent to obliterate the septum. So basically you balloon the stent all the way down to the aortic wall, but you can rupture if you're not careful. We have done in our institution a lot of stabilized cases. We routinely do them, but we are very, very careful. We never balloon more than the size of the native aorta. We use only non-compliant balloons, and when we balloon with the inflator, we are very, very careful. We go 2 atmospheres at the time, and we watch it very carefully. We have done a lot of these, 30 plus or more even. We never really had any rupture. This happened in a neighboring institution, and what you see, this balloon is, to me, it looks like it's a little bit aggressive balloon in here. You see the balloon outside of the stent area, as you see here. So that's too much balloon, and this balloon, it appears that's not compliant. Probably try low balloon. That's non-compliant. That's basically a compliant balloon. I'm sorry, it's a compliant balloon. Compliant balloon, when you balloon too much, it will respond. The non-compliant balloon is more constrained, essentially. So, and you see what they've done here. They put a balloon here to stop bleeding. You see the bleeding here, and then they end up doing EVAR on the patient, and they save the patient. But that's, it happens. We have to be very, very, very careful. That's why when you talk to people, stabilize 1 and 2, including Dr. Lombardi, I've heard him say once that you already have 97% aortic related or freedom from aortic related mortality. What do you need more? Why you need this technique? I think this technique has merits for sure, but is dangerous if you don't do it right, and you have to really try to figure out how it works for you and what best way to do it. Systematic review, excuse me, for basically a stabilized technique was done. They looked into multiple papers and excluded multiple reports. They ended up with 10 cases, and as you see these numbers of patients here, and the cases that they done, acute versus chronic, mainly acute, but there are some chronic patients as well. And mortality almost zero across the board, except one mortality. That's when you rupture, probably. And 30-day mortality is compatible with an EVAR mortality, TVAR mortality as well. When you look at the spinal cord ischemia, also compatible with regular TVAR, because this is an open cell stent. It's not cover stent, so you still perfuse the spine in that area, wherever you cover. So, and visceral ischemia, it's very, very seldom you get visceral ischemia. And by the way, if you need to stent afterward, you can stent still these SMA and celiac. A little bit harder, but you can do it. So stabilized technique is safe and effective. They concluded basically it's being considered a serious attempt to promote aortic remodeling. And again, that's on one camp. The other camp, when you talk to Dr. Lombardi, he's telling you 97% of these patients, there's a freedom from aortic-related mortality in 97% of the patient. But when you look at the false lumen thrombosis, only 81% of the patient had complete thrombosis. There are 19% of these patients who had partial thrombosis, basically, or 10% of those patients that had partial thrombosis, and 10 actually had no false lumen. These technically patients who have partial thrombosis, they could have aneurysmal dilation and things like that. So there is merit for it, and we do it. In our institution, we do it routinely. And I can tell you, we're very, very happy with the outcome of these cases, because we're seeing, even I'll repeat, I'll show you in a little bit, even a couple of days after a CT scan, you see complete, resolution of the false lumen. And I'll show you two cases. I'll show you one case where we ballooned stabilized technique and one case where we did not do stabilized technique. We just put the dissection stent. This is a 41-year-old male, came in with acute type B dissection, chest and abdominal pain. His white count was 11. He did not have acute abdomen, but he had tenderness in his abdomen. Lactate was around 4. Creatinine was about 2. So we did him semi-urgently. We placed a covered stent. It's right here, as you see. Then essentially we shot the viscerals, and as you see here in the viscerals, the false lumen is small. The SMA shows, but it's not as strong. At that point, we placed dissection stent, as you see right here, very carefully. You see how it popped up, but you have to be very carefully. We usually use a non-compliant balloon. We use the balloon is, in this case, we use Gold Atlas, and essentially we use it to the size of the aorta only. We don't we don't do it very aggressively. And it's another way. We balloon the overlaps, we balloon the entire stent, and this is the final picture. And you look at the now at the basically the you look at the SMA here. It's pretty nice. There's no problems. And if you look at the let me just delete this here. If you look at the this is CT scan was done like post-op day number 3. Almost there's no false lumen. That's why it's so appealing to do this procedure. So you see there was almost you don't see any false lumen. And that's why a lot of people, using this. But again, it's really very controversial. But look at the incredible results. And I have many of these CT scans. I have, over 20 probably plus CT scans like that. Pretty good outcome. This patient had, again, type B dissection with malperfusion. You look, very small false lumen. And the dissection stent was placed. In this case, needed to stent the renal. Usually, some people leave a catheter in before we do dissection stent. We don't do that routinely. Just so you know where it is. That's in this case, the kidney stent was placed. Then ballooning occurred, so you don't have to, because you have to flare the kidney. Again, it's non-compliant balloon. It's very carefully ballooned here. And see then the left, see the stent right here. So you don't want to flare the stent and then balloon afterward. The stent is deployed. And the picture looks pretty nice here. And the right renal was stented as well. Again, it's pretty nice. Already we ballooned. Already the aorta was ballooned. And if you look at the follow-up CT again, it looks incredible. I mean, it's hard to argue against that, But again, it's not without risks. And again, when Dr. Lombardi says that there is a 97% freedom from aortic-related mortality, that's also, without doing this, that also has a lot of merits as well. That's why currently there is a registry, international registry, registered in Italy and I think in the US as well, to look into a stabilized technique and what's the utility for it. This patient, the one that I talked to you about earlier, 41-year-old male with amphetamine use, came in with type B dissection acute, had hypertension but went away, was asymptomatic. We debated to do him or not to do him. We decided to do him because he's amphetamine user. His blood pressure gonna be a problem. Probably he's going to have a follow-up problem. But look at this false lumen here. False lumen has dramatically increased in size right here. It's really was large size, much larger than what we thought on the first CT scan. So he progressed even while in the hospital, which, I don't know if he's used amphetamine or not in the hospital, but usually we have, the people are in the ICU and watched very carefully. But look at the false lumen was so big that we're glad we did him. We would have scanned him, but he would have not showed up on the 2 or 3 week follow-up CT scan. We probably would have scanned him upon discharge. We used dissection stent here, but we did not do stabilized technique. We did not balloon this one. But still, if you look at the false lumen here, still there, we'll see what happens, but it's pretty, the true lumen is pretty open, it's pretty good results. And look at the sagittal views almost, and that's just 2 days after the procedure. In summary, the new high-risk features, they still need to be better defined. The definition of uncomplicated type B dissection needs also to be better defined. I think maybe better nomenclature would be asymptomatic or asymptomatic, honestly, because type B dissection by definition is a complicated disease. Dissection stents are incredibly helpful. There's a solid evidence now that it's very helpful for acute dissection. We saw stable 1, stable 2. Essentially, only at 5 years, only 10% of the patient has partial thrombosis of their in stable 2 trial. Stabilized technique, we use it most of the time. There's really not much data out there to support it yet. The best data that I could find is the meta-analysis that I showed you earlier. But we have, in our institution, we've done this a lot, and we've had a really, really good outcome with it, and a good remodeling. But we don't have a long-term data. Maybe these patients, if we would have not done ballooning, maybe they would have remodeled, or most of them. So one has to be really, really careful with stabilize and ballooning. If you do it, you have to have the right team, the right experience, and non-compliant balloon. And that's a brief presentation about acute type B dissection and how it's currently being managed. If you have any questions, please feel free to contact me. And thank you very much. Assalamu alaikum.